Compensatory deformities sometimes can develop as well, maybe pathological, or maybe even secondary to certain side of a surgery. Once we have done the corrective surgery, for example, when we are treating genovalgum, usually we have to go for some sort of surgery. But what happens is that in case of, for example, we are doing some form of physeal stapling over the medial physis, we may damage the lateral physis as well. Therefore, even despite the physeal stapling on the medial side, we may not achieve that sort of a correction which we were looking for in that case. Or sometimes what happens is that when we have stopped the medial physis, the lateral physis is actually growing and it leads to some homogeneous. Now this is some sort of a compensatory mechanism which actually occurs, so we have to be on the lookout for that as well when you're treating genovalgum and genovarum, especially in the case of children. If you look at this, for example, this child is looks like it has a bowlegs. When we are measuring the genovarum, we look at the distance between the two knees rather than the malleoli, and patient may develop later on. If you see, the surgery was done to correct this, but patient has developed actually the torsional external rotation of the femur. This may be due to secondary to the other problems which may be done during the surgery. There was inadequate soft tissue tensioning or inadequate soft tissue problems which may have resulted in this sort of an issue. So, or this patient may eventually develop genovalgum because of the continued growth of the medial physis and eventually leading to genovalgum. Therefore, when we are dealing with genovarum and genovalgum, we have to make it sure that we do not overtreat it. We have to treat a bit genovarum up to if a bit 10 to 15 degrees more than normal, but we have to be on the lookout for compensatory deformities which may develop later on and which will itself be another complication of genovarum or genovalgum surgery.